Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Richard Lawhern. He's a patient advocate. Today's Kevin MD article is titled Rethinking U.S. Opioid Policy. Richard, welcome back to the show.
Thank you very much. I appreciate being invited.
So, you've been on multiple times before. Go to kevinmd.com/podcast. Upper right-hand corner, there's a search icon. You can search for Richard's name to hear his story. But today, let's jump right into your most recent Kevin MD article, Rethinking U.S. Opioid Policy. So how did this article come together?
Well, I started looking at and comparing the CDC guidelines on opioid prescription that were published in October of 2022 against the report of a group that was chartered when the guideline revisions was announced. They were called the Opioid Workgroup, and they were reporting to the Board of Scientific Counselors, which is an advisory group of the National Centers for Injury Prevention and Control, which was the authoring group that founded the guidelines in the first place in 2016 and then revised them. I traced the concerns voiced in the final report on July of 2021, the final report of the consulting group, and tried to see how they might have affected the statement of 12 recommendations and a very large body of discussion and supporting material in the guidelines. And in doing that, I had to go back and redo some research that I had done over the years concerning the incidence of what we call iatrogenic or treatment-caused opioid addiction in patients treated for pain. I began to see some glaring inconsistencies and concerns. And I put together a rather long treatise on the subject, doing the direct comparison, and I shipped it to as many of the original participants in the opioid work group as I could find. There were about 18 of these people drawn from a wide variety of backgrounds, many of them with subject matter expertise. And I got back no commentaries on the details of the research I had done, and I was puzzled about why, and I kept pressing. It turned out that the opioid work group, when they signed up for service in this oversight role, each of them signed non-disclosure agreements.
Sure.
And we have to recognize that non-disclosure agreements do have a legitimate place to play at the stage where one is developing policy before it's published, because you have to protect people who are dealing with a controversial subject from either external influence that might in some way be coercive, or simply getting lost in a public argument that never goes anywhere. They have to arrive at some kind of conclusions. It's useful in that context, but there is a downside hazard to this kind of process. What I learned was that several members of the work group believed that the non-disclosure agreements they signed are still binding today. That means that they feel constrained. I think I'm being fair here. They feel constrained from commenting on the process that they went through to arrive at their concerns and recommendations.
Before getting into kind of the backroom scenes of how this new opioid guidelines came about, tell us the concerns you have with the recent update of the 2022 CDC opioid guidelines.
Absolutely, Dr. Foe. And that's why this whole process of trying to investigate is so important. I would represent to you and to those of it who are tuned in and watching that the CDC guidelines, as they were published, and to some extent the work group report as it was published 16 months earlier, reflect two fundamental conceptual errors that essentially destroy the credibility of the guidelines outright.
Okay.
And I'd like to name them and briefly discuss them. First of all, the CDC guidelines have multiple, in fact, over 400 mentions of the term risk. And they admonish clinicians that they should be analyzing and making a judgment on risks versus benefits for each individual patient that they treat with opioids. Now, that's a really pretty mundane idea when you think about it, except that there is no scientific methodology that allows a clinician to do it. In fact, no less an authority than the director of the National Institute on Drug Abuse, that's Dr. Nora Volkow, and one of her colleagues, Dr. McLellan. In the same month that the CDC guidelines were originally published in 2016, they put out a landmark article in the New England Journal of Medicine that was called Opioid Abuse in Chronic Pain, Misconceptions and Mitigation Strategies. And in that document, they lay out the concern, among other things, they lay out the concern that I'd like to quote. Unlike tolerance and physical dependence, addiction is not a predictable result of opioid prescribing. Addiction occurs only in a small percentage of persons who are exposed to opioids, even among those with pre-existing vulnerabilities. So what they are saying is basically, we know that we can predict risk in large populations, but there's no consensus in 2016, and I might add there still is no consensus, on how one might extrapolate from those demographic studies to help a clinician to actually assess the risks in any individual. Now, what that really means is there is no consensus on whether clinicians can essentially comply with the guidance that the guidelines have provided them. And there is enormous contention over that issue. And clinicians are being driven out of practice and persecuted out of practice because of it. So this is a very germane issue. Effectively, clinicians are being presented with a Hobson's choice. They withhold opioids because they believe a given patient may possibly be at risk for addiction. In effect, they guarantee harms to that patient in untreated or undertreated pain. However, if they prescribe at levels that exceed the relatively modest recommendations of the CDC guidelines, both original in 16 and updated in 22, if they prescribe at effective levels, they can be persecuted out of practice and imprisoned. And that, in fact, is happening on a large scale. So what we've got in the guidelines is a conundrum, if you want to call it that. It's a basic conflict. The conflict says you have to assess risks and benefits, but there's no methodology for you to do that, so we're going to leave you on your own. If the guidelines had acknowledged that conundrum, they couldn't have been published because they become moot. Now, there is a second major methodological error that both the guideline writers and the work group participants were aware of, because you can trace it in the documents. There's a 25-year history in medical literature that examines the way opioids are metabolized in the liver. And this can be made pretty complicated, but for your non-clinician readers, I'll try to simplify without oversimplifying. Basically, 6 key enzymes in the liver break down opioids and almost all other medications into component sub-elements, or prodrugs as they're called, that can cross the blood-brain barrier and have an effect in the brain on pain and on many other disorders. Turns out that there is a wide variation in the genetics of individuals, and that creates a range, a very wide range in minimum effective dose levels, and a very wide range in potential side effects of dosing. The range that has been estimated in work that I shared as a co-author with Dr. Stephen E. Nadeau is 15 to 1. There are some that can do fairly well on low doses. There are some, and they are rare, who are actually almost allergic to opioids. That's observed in clinical practice. It's well established. And there are some who can take enough opioid analgesic by prescription to knock over a horse, and they can hold a perfectly cogent conversation with you throughout the brief period of time in which those opioids remain in the bloodstream. So doses that are intended to last for 4 hours may pass through the bloodstream of a hypermetabolizer in 20 minutes. Now, here's the rub on that. The literature is out there. It is only vaguely acknowledged in one footnote to one table in the CDC guidelines. And it is mentioned only in the charter, which is an appendix to the work group report. But obviously, both groups were aware that there is a genomic or genetic component that significantly impacts the way opioids need to be prescribed and can be prescribed. Now, I'm going to offer a surmise. It's a surmise that's grounded on a great deal of research, but it's one that I want to see publicly explored in a conversation that the work group members need to have without restriction.
Now, tell me the reaction. You represent the patient advocate community. Tell me the reaction of patients when they saw the revision of the guidelines.
Horror, absolute horror. Patients are aware, and they've been made aware by multiple publications in places like the New York Times and Washington Week and a number of other places. They are aware that doctors are leaving practice all over America in pain management, that clinics are refusing to accept new patients because clinics want to protect themselves, that's to say for pain management. Clinics want to protect themselves from possible legal repercussions, and they are force tapering patients off of the existing levels of dosage. Basically, doctors and pharmacists are refusing to treat pain with the most effective clinical and proven safe techniques that are now available because they're afraid of being persecuted.
Now, tell me specifically with the 2022 update to the guidelines, what about them is causing doctors to rapidly taper opioid prescriptions?
Doctors basically are very risk averse. Doctors basically read the guidelines and they say, well, yeah, they say I got to estimate risks versus benefits. But they also say that there's a point of vanishing returns that I've never seen, above a dose of, let us say, 50 or perhaps 90 MMED, that there's a point of diminishing returns in the effectiveness of opioids. But there's no reference. In fact, there are no specific references from literature that identify where this estimate or this advocacy comes from. The guidelines never refer to a specific place that we can go and check that says, yeah, here's the evidence that says there's a threshold of diminishing returns that you shouldn't go above. So the doctors consult their lawyers, and their lawyers say, it ain't worth it, guys. These people are going to come get you no matter what. The DEA is going to persecute you out of practice and put you in prison if they can, if you prescribe any opioid to any patient for any reason at any dose. Now, obviously, I'm being emphatic here, but I have talked with doctors who have phrased the issue in exactly this way. Doctors are being intimidated, and the ones that aren't intimidated are being forced by hospitals and others to stop prescribing opioids. I've talked with patients, more than one, who were told when they went in to visit their spouses dying in hospital, no, I can't prescribe opioids because it might compromise my license. I was told that, in fact, I published it in an article in Reason magazine. I was told that by a lady out in California whose husband died of a brain tumor. She was with him, watching him cry in agony for the last 3 months of his life in a hospital room. And the doctors wouldn't prescribe opioids. They prescribed Tylenol, which is a little bit like going after a forest fire with a squirt gun. So this is a general problem. It is not an exception. It is affecting literally millions of patients and thousands of clinicians. And the CDC guidelines are at fault.
What do you suggest that healthcare professionals do with the current guidelines?
Ignore them, because there are major alternatives to the CDC that are far more balanced in the approach to this issue.
And like what? What are some examples?
Well, some examples would be the Federation of State Medical Boards has released and recently updated their guidelines. The World Health Organization Ladder of Pain Management was published originally in 1984. It is taught in medical schools. It has been validated by extensive clinical experience, and it provides a framework within which one may reasonably set up an orderly process for deciding which patients need opioids for what reasons, and then prescribe at a level that's effective to them. The standard, the standard not recognized by CDC, but recognized by many other clinicians, is if you believe that opioids are clinically indicated for a patient because other things don't work particularly well. If you've tried a few other things and you've decided, yeah, we don't see much help from anything else, then start low, titrate up slow, measure for side effects, diagnose and aggressively treat the side effects. If you don't get a good answer with one opioid, then taper it down and titrate up another opioid with a different mechanism of action, perhaps a different targeting of that opioid, or a drug cocktail. Document what you do on the way and verify the patient's reports by doing intelligent but non-punitive urine testing and blood testing where necessary. And likewise, although the World Health Organization doesn't mention it explicitly, there's increasing evidence that genomic testing for the enzyme activities in the liver can provide significant guidance on why a patient is not responding well to opioids or to a particular class of them. That's well established in clinical practice. Practically any doctor who has had experience in this field will see and has seen patients that thrive on doses not of 50 mMED, but of 3 grams a day. 3,000 MED is not all that uncommon. It's not extremely common. Let's not misrepresent that. But I've heard that statement made by clinicians in medical board meetings in California, particularly. That's the source of that particular observation. So the bottom line is document what you're doing, communicate and educate with your patients and with their resident caregivers, because you have to protect the patient from the possibility that they're going to be oversedated. You don't want somebody having respiratory arrest. And make clear that the patient's reports are important and that they're heard and that they're trusted, because without a sound clinician-patient relationship, nothing good can happen. We understand that.
We're talking to Richard Lawhern, a patient advocate. Today's Kevin MD article is titled Rethinking U.S. Opioid Policy. Richard, tell us some of your take-home messages that you want to leave with the Kevin MD audience.
The take-home messages that I would offer is talk to your doctor. Tell him he can't use the CDC guidelines because they're scientifically flawed and known to be. And write, or better yet, phone your legislature and demand that they take legislative action to remove the CDC guidelines as a de facto standard. Anyone who wants to reach me can do so. I am about as visible as a highway flare in the Google search, and several of my articles include my email address. Likewise, reach out to other patients in social media and realize that you're not alone. You're not fighting this fight alone. You have other advocates, and I am by no means the only one of them.
Richard, thanks again for coming back on the show, sharing your time and insight.
Thank you, Dr. Foe. It's greatly appreciated, and patients will bless you for making this visible, making this whole issue visible.